So again, yeah, thanks Claire, thanks Ian, and hello everyone. For those of you who don't know me, I'm Pramit Patel, GP, and I am the ICB partner member for Primary Care Medical Services. So like Claire, before I carry on, right, I just wanted to apologise for the wordy slide deck that's going to be booming on your screens. Apologies, there's a lot of content in here, but I'll canter through these slides really quickly. But again, like Claire, I'd like to put on record my huge thanks to everyone who's contributed to this, to our response, our Surrey Heartlands response to the fuller Stocktake. I think it's been an amazing and a fantastic few months really since the report was published in May this year, and our teams led by our 4 place leaders have done a fantastic job, a tremendous job, you know, going from big tents in Surrey down strategy days in Northwest, place-based events in Guildford and Waverley, and again away days in East Surrey. And those events have brought together colleagues from voluntary care, secondary care, primary care, community care, district and boroughs, local authority, and our own teams from the central ICS as well. And what this journey has shown me is that it's created teams of teams at every single level. And I think that's exactly what the Stocktake is about. It's about creating multidisciplinary teams right from practice through to system. So I think it's been an amazing journey so far. So attached in your papers is a full 43-page. Next, back one, please, Ryan. Yep, thank you. So attached in your papers is a 43-page report. It gives a lot more detail and offers some fantastic case studies from across our 4 places, and it actually brings the document to life. And when we were drafting this particular report, and Karen McDowell was working very closely with me and colleagues as well from her team, it became quite clear that this document was actually based on response from the 4 places, was about, you know, setting the direction and the conditions as a system to empower our places and our teams to create those thriving and empowering integrated neighbourhoods. And at the heart of the document, there are 2 aims. One is to make it easier for our patients to access care when they need it. And 2 is to create the time, the headspace for our clinical teams to provide that continuity of care to those patients who really do need continuity. Next slide, Ryan. Thank you. So we've spoken about our critical 5 previously, and that talks about keeping our populations well and help those who need urgent care to make sure they get it in the right place first time round. We talk about helping with safe and effective discharge from our hospitals. Now, when I speak to my patients in practice, they think we are one big NHS family. Our populations genuinely think we're one team, regardless of whether you work in a hospital, in the community, or in general practice. And what this report offers, it gives us the opportunity to actually make that real. Let's start joining it up. Let's create those integrated neighbourhood teams of teams, and let's work together, you know, across all of our organisations, across the whole of Surrey Heartlands. Ian, you talk about high-risk care management programmes, and you know, we know who our most vulnerable and our high-risk cohorts are. For example, and I'm just going to say this now because it has been referenced in the winter plan paper from Amanda Pritchard and David Sloman. Thank you, Claire, for sharing the stats. We know that 64,000 residents living in East Surrey are high users of healthcare services, of which 1%, so that's 624 residents, are at high risk of admission. And I must say, not all of these are actually medical reasons. So out of that 624, they had 1,900 or approximately 1,900 ED attendances, 500 outpatient appointments, 500 inpatient stays, and approximately 55,000 GP contacts. So what we need to do is to start building multidisciplinary, multi-agency teams of teams to wrap around these cohorts, a bit like what we've just heard from Janice's work and Karen's story, is build the teams and wrap around these cohorts where they can actually receive personalised continuity, health and care support. Critical number 4 talks about effective hospital management. You know, what does that mean for us? That means how can we help patients leave hospital ASAP to prevent them from further deteriorating or deconditioning, and that does require health and care colleagues working within neighbourhoods as a team. So whereby patients can be discharged seamlessly and back into the community, doesn't matter where they go, whether it's at home or a setting, our community teams are ready to accept. And to make this happen, it requires system-wide conditions and it requires system direction. So we need robust digital data and estate strategies which allow place committees made up of health, district and borough, voluntary care and alike to deliver those objectives through the neighbourhood teams. So from Claire's work in May, there were 3 themes that came out loud and clear. 1, integrate urgent care. So that's really about streamlining access for patients, who access healthcare. At the moment, it is so chaotic and it's leading to increasing amount of unmet need. And as a result of demand failure, it's therefore leading to rising activity levels. We need to streamline the access points to make it easier for our patients to get the care when they need it and how they get it, and make sure it's first time round. And that way we'll actually improve the experience and also the satisfaction and the outcomes as well. 2, complex care and chronic care. So as already mentioned, we know how much, a few of our patients, value having continuity of care. But with population numbers rising and people living for longer and having more complex and chronic conditions, we need to start using our population health insight teams to be able to segment and stratify our populations and build teams around these cohorts with care coordinators, social prescriber link workers. Janice, you spoke about them previously, health and wellbeing coaches, mental health practitioners, frailty teams, and having that support by GPs and consultants as part of the multidisciplinary team. And what you'll see in the paper, in the One System, One Plan document, is that we've got some fantastic examples of this happening, and we've already heard one this morning. And third, we talk about prevention and long-term conditions. And I think this is where our focus really needs to be. Before patients and residents fall into the complex cohorts, there's a lot we can do to keep our population well. What we do need to do is be clear who our seldom heard cohorts are and where they are. We need to reach out to those pockets we all know we have within our neighbourhoods. We need to understand how we can start addressing those health and social care inequalities. We need to improve our vaccination and immunisation uptakes. We need to improve our smoking rates. We need to improve our severe mental illness health checks, as well as learning disability health checks. And we need to pay more attention on the child and young people, the children and young people cohorts, who I see in practice quite frequently. They actually do have medical and social complexities. And through these 3 approaches will emerge our multi-agency, cross-sector integrated neighbourhood teams, and they are now evolving from our primary care networks. Next slide, please, Ryan. Great, thank you. So I think when we start talking about engagement, we need to start moving away from the traditional way of engaging with our populations. So shaping our approach with our communities is going to be more important now than ever. And health is no different to any other industry. And as I said, let's move away from designing services we think that our patients need to co-designing our services with our populations. So from population health insight packs provided to our PCNs, it's clear we can't build a one-size-fits-all for all of our neighbourhoods. We need those local insights at a neighbourhood level. And this is where we should be guided by our clinicians, our professionals and our patients shaping what that offer looks like. So from a population health management perspective, I always use this figure and I use it frequently. It's only 10% is about the data, but 90% is about the engagement and the relationships built within those entities. And that's where the magic starts happening. And as you can see, that middle column, and we've got some great examples of engagement happening in each of our 4 places. And we've heard from our place leaders in respective deep dives in previous events, over the last few months, of how we're shaping that as a system. This isn't just about providing the immediate insight. We need to redesign services around neighbourhood teams. And more importantly, it's about helping us to know how we can hardwire the voice of our communities into everything we do going forward. And that's basically working with our people and community strategy that's emerging through the system. Making neighbourhoods real for patients is critical if this is going to work. If it's not real for them, if it doesn't work for them, this is going nowhere. So we need to allow them to guide this development and help us with the implementation as well. So moving forward, we expect neighbourhoods and places to have stakeholder mapping events, to host events with residents, colleagues from district and boroughs, social care representatives, and let's tap into our vibrant, voluntary care organisations as well. And I know, Sarah, you're in the room. We need to bring in schools, community pharmacy, optometry, and dentistry, as well as local councillors. And we're seeing this happen in places. And, we've got a fantastic example in Hawley where the fantastic Dr. Giloro has been championing this way of working for the past couple of years. And what we expect now is more community projects supporting local wellbeing preventions, and how we sort of scale and spread that across the system is going to be part of our journey. So we've sort of moved to the next slide. It's clear from our clinicians and our residents how important it is that we put in the right infrastructure, the technology, and the support to help ensure that our patients see the right person the first time round in the right place. And to make this work effectively, we're recommending 5 key developments for every neighbourhood team. 1, creating clear, reactive and proactive models of care based on teams of teams, such as our advanced nurse practitioners, clinical pharmacists, navigators, paramedics, physician associates, working alongside GPs and other specialists. Our reactive team is also a multidisciplinary team of nurse practitioners, navigators, GPs supporting as well. And we need to help, support those folk who need an urgent appointment and flow them to the right place, be it the minor injuries unit, urgent care centres, walk-in centres, or our community pharmacy colleagues. Now, if we're able to streamline the access and the reactive model of care, this should help release some capacity for practice teams to refine the proactive model, such as long-term conditions, including medication reviews, improve the quality and quantity of annual health checks for our learning disability and severe mental illness folk, improve the immunisation and vaccination uptake, improve the screening targets for bowel cancer, cervical cancer, breast cancer. More recently, Louise, again, we spoke about this earlier in the week. We've got some great initiatives of improving the prostate cancer detection rates as well. And an example that's been rolled out, that's been piloted in Guildford and Waverley, is where the team over there have partnered with a virtual hospital provider to help improve detection of prostate cancer. COVID hasn't cured prostate cancer, but we've seen a reduction in the number of people coming into practice with prostate issues, and therefore the referrals into our secondary care has dropped. So what the team in Guildford and Waverley have done is they've targeted 500 men using the population health management approach, and really started to bring them into these one-stop clinics. And really the aim now for us is to spread that innovation across the system, and that's how we're going to improve our detection rates sort of widely across Surrey Heartlands. 3, cloud-based telephony. Now, I keep on banging on about this. In my opinion, this really is a game changer. It will help improve the patient journey experience, and it offers some great tools such as a queue button technology, so patients don't have to wait on the phone for long periods of time when they call their GPs. But it also starts allowing practices to analyse the demand data, so gives practices and PCNs the ability to map capacity effectively, and it also, more importantly, creates a consistent and standardised access point for patients. And the opportunity that it offers is that we can start thinking about creating centralised teams, be it neighbourhood footprints, place footprints, and that's and we've already got some good examples happening in East Surrey through the work that Karen and Shimona are leading in the coordination centre. 4, as mentioned earlier, we've got some examples of best practice across the system where teams are already coming together, such as frailty teams, and our integrated teams can be made up of our existing and new primary care network roles, hospital specialists, therapists, community nurses, and it's about creating that seamless link to other parts of the system which we're designing and creating at the same time, such as our community diagnostic centres. But it gives the ability to step up, if patients require step up into the virtual ward space, it allows that continuity of care to happen in the patient's home. And at the same time, that releases capacity elsewhere in an already overheated system. 5, as Michael Patlin, our Chief Digital and People Officer, often says, healthcare is a contact sport. However, our teams are growing and we're running out of space. So again, we have our one public estate strategy, which I think is a key enabler if we're going to be able to provide the right environment and conditions for our teams to work productively. And I'll talk about that a bit later on. Next slide, please, Ryan. So a key element to improving the experience for our patients is who access healthcare services is to start defining and detailing our approaches to access. So if we can improve that front door experience by offering seamless and excellent triage, flowing our patients to the right person in the right setting first time round, rather than patients having to go through, for example, 6 contact points to get a course of antibiotics for a UTI, we're more likely to create capacity for clinicians to see patients who do need that continuity of care as well. So in doing so, we're able to improve the quality of care we give, and then we can start shifting away from that traditional 10-minute appointment. And Karen said it earlier on, didn't she? The GP doesn't have time currently. But if we get this bit right, we can start moving from that 10-minute traditional appointment model to 50 minutes or longer. And we've got, examples from places that teams within neighbourhood footprints are developing urgent care access hubs, and this should also help, keep our patients out of the EDs. Triage teams can start directing those patients, the suitable patients, to the urgent care response teams. Those patients who fall in the complex frail cohorts, who may then have the potential to onboard into virtual wards. And again, this avoids the transport from patients away from their homes and reduce admissions as well into our already busy hospitals. So through seamless access, triage, we can start flowing patients into community diagnostic centres as well. And if I just share an example, a patient who may have palpitations has been triaged and seen by the urgent care team, they can then flow that patient seamlessly into community diagnostic centres for further investigations, such as cardiac physiology, for example, and then be referred back to the patient's own GP to manage or seek advice and guidance from hospital colleagues. This would result in more prompt diagnosis and management for our patients without having to wait weeks and several months for an outpatient appointment. However, this model of care does require a shift in culture. It requires secondary care consultants and clinicians working alongside primary care colleagues within those neighbourhood footprints. But therein lies a real opportunity to start actually integrating care. Our Ageing Well programs are based on the 3 pillars, including enhanced health and care homes, anticipatory care, and urgent care response teams. Our integrated neighbourhood teams have the ability to segment and stratify populations and build caseloads managed by care coordinators who can then start coordinating their care between geriatricians, matrons, pharmacists, and GPs. But let's also bring in our adult social care colleagues into the mix, as well as social prescribers and voluntary care. So if I just put this into context from a patient or a carer's perspective, should they require urgent help and they are already known to the frailty teams or anticipatory care teams, they would still call their own practice, who will either ask the urgent care response team to visit and feed back to the frailty teams, or through the new cloud-based telephony system, that call could be passed over to the integrated neighbourhood team care coordinator, who already knows that patient and their situation and their circumstances and their best place to support that patient or carer. And in effect, is offering personalised continuity of care, but delivered by a multidisciplinary team of teams. Next slide, Brian, please. Perfect. So estate, in order to be able to deliver this new model of care, or this model of care rather, we were quite clear from the outset that there are 3 enablers that we need to make sure we have. 1, estates, 2, digital, and 3, workforce. And what we've learned through COVID is that whilst remote working has its advantages, nothing beats face-to-face human contact. And I've already mentioned that it's a contact sport. But with growing multi-agency, multidisciplinary teams within our neighbourhoods, co-located space is proving to be a challenge. So, using the principles of the one public estate strategy, we're fortunate to have dedicated teams now working across the ICS to identify opportunities And across all 4 of our places, we've got teams working with partner organisations to help do the baselining estate and understand the state and conditions, as well as the cost for all of our healthcare settings, including general practice. We want and we will develop new investment principles across the system to help support the decision making on how we prioritise on projects and the capital spend with it too. But I think the key principle is that we still want to retain a state within the public sector. We want to identify opportunities for co-located space, and Surrey Heartlands is one of 6 pioneer ICSs as part of the NHS England Cavell programme. And that programme looks at a new ownership model, and for us it's the Staines Cavell Centre, which it will be a state-of-the-art centre in community health and wellbeing building, offering a range of services closer to the patient's home. And to make all that happen, we need to develop a blueprint for the governance and delivery, of multi-partner place projects. And if we get this estates bit right, it becomes a catalyst for integration, because we know if we know what the patient's needs are, we can then start developing the services. We can then start working out we can start developing the workforce plan, and that will then help inform the estates piece as well. So what we need to do is we need to be able to explore, but at the same time exploit opportunities. And more importantly, it's our responsibility within the ICS to be able to provide an environment where our workforce feel happy and proud to work in and also train in. Next slide. I'm just going to canter through these and I'll be really quick now. So talent mapping. In order to sort of deliver our services in an integrated way, we need to build expertise. We need to develop talent, and we need to think differently when it comes to recruitment. So Michael Patlin has previously presented the United Talent Strategy the inaugural ICB in July, in fact, and that was created now by our ICS teams on teams. And what this outlines is we need to be bold and modernise recruitment. This means let's integrate our recruitment across a range of parties rather than having people, submitting multiple applications. Let's make it easier and let's get them to do it once. Let's build new capabilities within teams. So, we have the Surrey Heartlands Health and Care Social Academy, and that will be, the purpose will be to develop and nurture talent across all settings. So let's create rotational programs for our students and other roles by exposing them to primary care and community care settings, as well as social care settings. Developing, fulfilling careers. We need to be clear about our, how we create those career pathways. And Claire, you often talk about, don't you, about having structured career programs for anyone in healthcare systems. So how do we help develop our own workforce? For example, how can we develop our front of house receptionist to progress to being an office manager, to then being an integrated neighbourhood manager, to potentially manage within place and system? Let's create an exciting Surrey offer and become an attractive place to work. Let's look at how we can prioritise the affordable housing opportunities for our workforce. And let's also think about childcare for our workforce too. For example, SASH have a great on-site creche, but we need to do more of that in the community. But in order to do all of this, we need to be able to invest in our leadership support at all levels, from practice through to neighbourhood, place and system. And this is where our leadership framework under Claire Stone's leadership sort of will help bring all this together. It's like programs like Surrey 500, the various leadership programs, often being developed nationally and regionally. Let's start aligning them and let's create a diverse and strong multi-professional health and care leaders network within Surrey. Next slide. So at the core of our transformation lies our digital and data strategy. So the data strategy is all about empowering places to understand and provide analytical and insight supports to help that decision-making process at the neighbourhood footprint. It will also then allow our team of teams to understand the data, bring together the multi-agency colleagues to literally and properly co-design and co-deliver those services, which make a real positive impact for our population. And I said this before, that in a nutshell is population health management, 10% data, 90% relationships. And that's that 90% where those relationships are developed in those teams, that is where the magic really happens. And in addition to data, we need state-of-the-art digital technology for our patients, residents, and our neighbourhood teams. And we're fortunate in Surrey Heartlands that we were one of the, Surrey Heartlands was a local healthcare record exemplar. And through that, we've got the Surrey Care Record. Now, with all of our hospitals being on, the same electronic patient record platform, we've got rich data there. We've got rich primary care data. Let's, overlay it with social care data, hospice data, community care data, mental health data, and that becomes a powerful tool for our integrated neighbourhood teams because we've then got one version of the truth. And this is where data integration becomes a catalyst for an integrated team to deliver integrated care. And we need to use digital technology to make it easier for our patients and our GPs, and our colleagues across the system. So GPs have been promoting the NHS app now, and we've got over 61.2% across Surrey already signed up. But there's so much more we can do to make our patient journeys and experience even more slicker. Next slide. So what we do now, what we build now, has to be sustainable. So what we need to do is we need to ensure local flexibility. We need to have local flexibility and accountability, but at every single level, from integrated neighbourhood teams to place to system. And that is going to be, it's going to be key for sustainability. It is key that if we strengthen the local leadership, that will result in sustainable primary care. There's no doubt about it. Our place-based partnerships or our alliances will set the local direction for delivery, while transformation, innovation and quality committees will track and oversee the operational elements within the neighbourhood teams. And that's why we as a system are committed to continuous care, quality improvement at every single level. And we've now got an established quality improvement collaborative. And as a system, we lead the clinical strategy through the Health and Care Professional Committee, which is co-chaired between Charlotte Caniff, our joint CMO, and Claire Stone, our multi-professional leader. And finally, sticking to the point of supporting every level of care, my primary care colleagues are undergoing a series of access visits across Surrey, Heartlands, to understand what support we can give to practices such as CQC inspection help, and trying to create that consistent and standardized operating model. Final slide. So Ian, this is my final slide, I promise, before I hand back to you, but this is the so what slide. And how will we know what we are doing actually makes a difference, and how will we know whether we're succeeding or not? So access. We should see a rise in patient experience and satisfaction outcomes, making sure we deliver timely access in the right setting. Continuity of care. We should start seeing an increase in personalised care delivered by resilient multi-agency, multidisciplinary teams, not necessarily seeing the same GP, but seeing members from the same team. And we should start seeing a reduction in the number of GP contacts, inpatient numbers, ED attendances for those defined cohorts, such as the 1% I spoke about earlier on. And finally, we should start seeing that inequalities gap close. We should start seeing a rise in the vaccination and immunisation uptake. We should see a rise in cancer screening uptake, a rise in early cancer diagnosis, a reduction in smoking rates, improving our blood pressure targets and our diabetes levels, especially in those cohorts who aren't traditional healthcare seekers. So I have rattled on. I hope I've been able to give you a useful synopsis of what our teams have been doing over the past few months. But please, if you do get a moment, have a read of the document. It's a really high level document, but all I would like to say is it's been a mammoth effort from all of our place members, partners, organisations. So I'll hand back over to you, Ian.